Hello everyone, welcome to Dentium Live Surgery session today. I'm Young Woo Song from Veterans Medical Center Hospital, and I'm a periodontist, and I will be presenting my video, which I did vestibular deepening at implant second surgery with collagen graft. So let me introduce the patient information first. The patient was 58 years old. He was male patient, and he was referred from prosthodontic department of my hospital for placing 2 implants on number 24 and 5 area. So he had past dental history of implant placement on number 16, 15, 14, and 26. And right now, at the time he came to my clinic, he had generalized calculus deposition on the entire dentition, and also he had severely lost alveolar bone at number 24 and 5. So my plan was for the periodontal treatment and maintenance, I plan to do scaling root planning first, and then extracting of number 25 and 24, and then placing Dentium SuperLine II at number 24 and 5 site, and then at the second stage, I was planning to do apically positioned flap for vestibular deepening on the buccal side along with collagen graft x1D. So this is just before the implant surgery. I extracted number 24 and 5, and then after 2 months of healing, we can see that the mucosa has been healed well. And from CBCT, we could see that there will be a bit insufficient alveolar bone, especially for the palatal side. And also on the axial view, we can see that there will be a bit of horizontal depression on the buccal side as well. And this depression will be presented on the apical of the implant. So we open the flap. As we expected from the CBCT, we can see clinically there is a palatal dehiscence defect, and at the apical, we can see that there was a depression as well. So we placed Dentium SuperLine II, which was 4 millimeters in diameter and 8 millimeters in length. And then we placed osteon 3 collagen on the buccal side and palatal side as well. After placing the graft material, we covered the graft materials with resorbable collagen membrane, and then we had primary closure of the flap. And 2 weeks later, the patient came back to the clinic for stitch out, and we can see that the site has been completely healed and with a perfect epithelialization. So as you can see in the clinical photograph on the right bottom, we can see that because of the GBR that I did, we pulled the flap coronally, so the MGJ line, the mucogingival junction, has been shifted to coronal. So this means that if I do not do any kinds of vestibular deepening, the prosthesis will be placed right next to the movable mucosa. So that means we need to do something to deepen the vestibule and optimize the buccal side soft tissue with keratinized immobile tissue. So this is the CBCT taken immediately after the implant placement and GBR. You can see that osteon 3 collagen has been perfectly placed where I tried to place. It is well preserved at the site that I placed. And then we can see on the axial view of CBCT, the most right section, the most right photograph on the slide, we can see that horizontal depression has been resolved. So the material that I will be using at the second stage surgery is collagen graft x1D. This is a pure type 1 collagen from porcine, and it is a collagen matrix for soft tissue regeneration, and it promotes fast epithelialization even when it is opened, even it is not submerged by the mucosa. So we can use this material for open membrane technique as well. So I brought similar cases that I followed up for a while. So this patient needed to extract number 15 and 16, 23, 24, and 25. So both sides will be extracted and placed by implants, and then both sides had vestibular deepening by APF at the second stage surgery. So let's look at the right side first. After the extraction, after the mucosal healing, we opened the flap, and this time as well, we placed Dentium SuperLine II. And then as well as just I did by my for my previous surgery, for GBR I used Austin 3 collagen for the buccal contour augmentation and dehiscence defect coverage, and then I achieved primary closure of the flap. The healing was fine, but as you can see at the right side, the most right clinical photograph, the mucogingival junction has already shifted to coronal after the GBR. And CBCT shows that the bone grafting has been successfully done. And at the second stage surgery, we did apically positioned flap, and you can see that I did periosteal fenestration during the surgery in order to keep the MGJ line at the apical as much as I want. And this technique is very critical in order to prevent relapse after the vestibular deepening. And at the level of periosteal fenestration, I fixed the partial thickness flap of the buccal side to at the level of periosteal fenestration. And then I placed healing abutments. So the periosteal fenestration is not just experience-based technique. It is evidence-based technique by several previous articles, and representative articles were from Yonsei University Perio Department, from Dr. Hong in 2025, and also in 2021 there was a nice clinical research from Chosun University Perio Department from Dr. Lee. So after the vestibular deepening and second surgery, after 1 week, we did suture removal, and we can see that very nicely shifted buccal mucosa to the apical, and then the healing was fine. But as you can see in the photograph taken 1.5 year checkup, still there is a bit insufficient thickness of mucosa on the buccal side. So this means we did achieve deepened vestibule with more immobile keratinized tissue, but thickened keratinized tissue was not able to be achieved. So this means there might be a need of some kind of grafting, such as free gingival graft or grafting collagen graft. But as you can see in the CBCT, the hard tissue condition was well kept during the follow-up period. Okay, let's look at the left side this time. After raising the flap, we can see there was a parallel defects. So after placing the implant, there was a need of palatal GBR as well as buccal GBR. As you can see, there was a fenestration defect for the number 23 implant. So after placing Austin Zeno this time, we covered the graft materials with resorbable collagen membrane, and after that we achieved a primary closure of the mucosa. And as you can see in the CBCT, the graft materials was well localized at the site that I grafted during the surgery. And as you can see in the photograph on the left side, right before the second stage surgery, the mucogingival junction has been severely shifted to the coronal, almost above the crest. So what I did was vestibular deepening by apically positioned flap. And after raising the flap, I fixed the partial thickness flap on the buccal side at the level of periosteal fenestration line. And then I covered the denuded connective tissue part with collagen graft x1D. I used this material instead of free gingiva. And you can see the photo on the left side. This one was taken at 2 days after the surgery that I did dressing after the surgery. You can see that epithelialization has been gone through very fast. And then after 2 weeks with this suture removal, then you can see that the site has been already epithelized successfully. And recently, the prosthesis has been delivered, and you can see that on the buccal side, we achieved deepened vestibule as well as thickened keratinized tissue, which is immobile. And if we compare this to the right side, we can definitely tell that the mucosa has been thickened compared to the right side, which I just did APF only. And CBCT taken after the prosthesis delivery, we can see that the grafted site has been well preserved during the follow-up period. Okay, so let's look at the video of the case that I did recently. So I'm starting the partial thickness flap raising, and when I do the incision, I try to keep the incision line above the mucogingival junction in order to have the partial thickness flap to have at least 1 or 2 millimeters of keratinized tissue. Now I'm raising the partial thickness flap. And using tissue forceps instead of pincet, I hold the flap and then I release the flap from the periosteum. And at this stage, it is important to leave the periosteum only at the recipient site and try to include all the elastic fibers to the partial thickness flap part. It is important to just leave immobile periosteum on the surface of recipient site. And if you use pincet to hold the flap, you can feel that the pincet is kind of slippery, so you may hold the flap a bit strong, but that's not good for the tissue morbidity, in terms of tissue morbidity. So this part shows that I'm doing periosteal fenestration, and this is the way how I intentionally cut the periosteum in order to traumatize the periosteum, and this trauma will lead to have scar tissue which will block the mobile mucosa to relapse coronal into coronal direction. So now I'm doing the suturing at the level of periosteal fenestration line. So the needle needs to bite the periosteum and then tie it. And after tying, you can see that partial thickness buccal flap has been well fixed at the level of periosteal fenestration line. And we need to repeat this suturing a few times more in order to immobilize the flap at the site that we want to fix. So another bite of periosteum suture in order to immobilize the buccal flap. So when the suturing is done, you could see that there is a denuded collagen, the denuded connective tissue layer above the partial thickness flap, and that part will be healed by immobile keratinized tissue since we shifted mucogingival junction apically, and since we included at least 1 or 2 millimeters of keratinized tissue with the partial thickness flap. Okay, so it is important to fix the flap thoroughly, and it is important to make sure that the partial thickness flap we shift to the apical direction and shifted partial thickness flap needs to be completely immobilized. Okay, then I think this will be the last stitch on the mesial side. And every time you do the periosteum suture, the needle always hits the bone part, and that would make the needle blunt than before. So if you feel any kinds of blunt needle, you need to change to the new needle. So now at the denuded connective tissue part, I'm placing collagen graft. Before I place it, I trimmed collagen graft, and then just as we do during the free gingival graft, we fix the collagen graft with suture material. And this time as well, it is important to immobilize the graft, immobilize the collagen graft. Since this collagen graft has very nice property, very nice mechanical property, it is very easy to bite the collagen graft and then just suture it to the recipient site. It is almost same to suturing free gingiva to the recipient site. So a few more sutures will be needed to immobilize collagen graft. And I use this material instead of free gingiva, but also I like this material because it does a function as a dressing material, because denuded connective tissue layer always has spontaneous bleeding during the, let's say, 2 or 3 hours after the surgery. But if you place collagen graft here, you can control the bleeding more efficiently. So when you immobilize collagen graft, this time we also need to do the periosteal suture in order to fix the collagen graft to the periosteum. So after fixing the collagen graft, I placed 2 healing abutments, and this healing abutment was placed by flapless procedure, just having one stab of incision on the crest, and then I just placed it without any suture. So this took around 10 minutes, but let's say if we did free gingiva graft, it will have a lot more time to do this. So another case, this case is from Dr. Sungmin Chung, who is the founder of Dentium and dentist himself. So he placed 2 implants on this edentulous ridge on the maxillary anterior side. Now he's elevating full thickness flap. The case that I showed before, just before, my case, used collagen graft instead of free gingiva graft at the second stage, but this time Dr. Chung will use collagen graft 2 as a barrier membrane in order to use it as a barrier membrane during GBR, but also he wanted to function the collagen graft as mucosal thickening material. So he's placing bright tissue level, 2 fixtures of bright tissue level, and as you can see, this time there is a decent defect on the mesial side, and there is also need to do some hard tissue augmentation on the buccal side. So after removing the rubber cap, he is placing the scan body healing abutment. And then for GBR, he is inducing some spontaneous bleeding by decortication using rotary burrs. And then he's placing collagenated bone, which is Austin Zeno collagen. And then for barrier membrane, he just placed collagen graft 2, and then he's doing some releasing incision in order to have nice closure of the mucoperiosteal flap. So he placed 1 Genos pin on the mesial side to fix the flap, and then he is closing the flap with suture material. So as you can see, between the 2 fixtures, there is a open healing area, but it doesn't matter at all because as I introduced in the beginning, collagen graft 2 has very nice healing potential, even it is not submerged by mucosa. So that part will be perfectly healed by secondary healing. And this part, he is closing the interproximal area, combining Palazzi technique. And then after the procedure, he is injecting PDRN for faster healing. And then he is checking the osseointegration after the surgery. So this is the clinical photograph after the surgery, and you can see that the GBR and implant placement has been perfectly done. And now, after taking intraoral scanning, he will be making provisional by 3D scanning and CAD/CAM technology. So the provisional has been delivered successfully. And you can see the healing is decent, nicely healed mucosa, even though the site was open healed. So for the definite prosthesis, a few more works were done by digital workflow. And then the final prosthesis has been fabricated. So this is before the surgery and right after the surgery. And the ridge atrophy has been recovered by GBR. Yes, and this is the final part of the video. So we're going to have 5 minutes break, and you can have some time to ask question if you want. And after the break time, we will answer the question for you. Okay, welcome back to live surgery. So this time I'll show you some post-op radiographs and clinical photographs after my surgery. So as you can see in the panorama radiograph, number 24 and 5, two fixture was placed, and then healing abutments are connected. And the left side shows the initial stage before the APF, and after 1 month, because of the collagen graft, the epithelialization has been well done on the buccal side with deepened vestibule on the buccal side. And this part, the deepened vestibule, has been covered by immobile keratinoid tissue, which will optimize the condition of the fixtures during the follow period after prosthesis delivery. And you can see the CBCT taken after 4 months after the GBR. We can see that the GBR site has been well preserved during the healing period in terms of horizontally. Also, on the cross-sectional view, you can see that the fixture has been covered by decent hard tissue on the buccal side as well. So there, we had two questions during the break time. The first one was, why did I choose APF with collagen graft x1D instead of free gingival graft? And my answer would be, of course, I could have chose free gingival graft for vestibular deepening as well as keratinoid tissue thickening. But in terms of patient morbidity and the treatment time, I wanted to have nice results in a more efficient way. So using collagen graft instead of using autogenous tissue, I could save a lot of time, almost like 30 minutes during the surgery. And also the patient does not need to have additional surgical site, which will be the donor site on the palate. That's what I chose collagen graft instead of free gingival graft. And the second question was, when do I usually evaluate soft tissue thickness gain after the surgery? So my answer is, in terms of regarding the healing process after the soft tissue augmentation, the connective tissue maturation, it takes 8 weeks, at least 8 weeks after the surgery, and the epithelialization, it takes at least 4 weeks after the surgery. This means that the total soft tissue maturation, it will take over 8 weeks after the surgery. That means we need to evaluate the soft tissue healing at least after 8 weeks. And during the healing period, we do not need to do any kinds of like probing, because it is during the healing period, it is very temporary environment. So after 8 weeks, we can finally evaluate the soft tissue thickness and soft tissue healing after the surgery. Okay, this is all I have for you today. Thank you for watching today.